All right, so let's talk real quick about psychosis, because it's one of those topics we can just cover quickly. That's a joke. Because there's a lot to it. People don't have a lot of experience with it. Everyone's felt down, so depression's one thing. We've all had mood swings. That's a little bit different. We all know somebody has a mania, and we've all had anxiety 4 or 5 times throughout the time we're sitting in the classroom. So like those are easier to kind of be like, oh, anxiety. Now the downside of that is I talked about it earlier, is we have a tendency as clinicians to use our clinical body of knowledge on things we don't have experience in, and we use our personal body of knowledge on things we personally experience. Oh, I know what it's like to have anxiety. No, you know what it's like when you have anxiety. That doesn't mean that's what it's like when somebody else has anxiety. Great example, I had a client today, and really severe anxiety to the point where they have a job that's very specialized. They're the only one in America that does this job. And they're so good at what they do in this job that's highly specialized. They've developed something that nobody else has developed, and they are the one who can, when companies have problems with it, they have to go to this guy to rewrite it. And so, but this guy is so good at what he does that, I mean, the pressure is constantly on to better what he's done and make it even better. And so he has had a lot of anxiety, to the point where he's on disability, I think. He can't work at this point because anxiety is so bad. So that being said, we find out today that we began looking at, because the triggers for anxiety were all over the place. So we began working on changing the body physically to affect the emotions. And so client found out that when he does 15 to 20 minutes a day of stretching his head in all 4 directions and uses a heating pad on his neck to relieve tension in the neck, immediately he gains his appetite, stops all anxiety, and he gains his sense of smell. He said, my sense of smell, my olfactory system stops working. Now we know, if you've already gotten the book, Why Zebras Don't Get Ulcers, that parts of the body that are not necessary shut off when you're in fight or flight. And so when he is heightened by anxiety, his body says, you don't need to smell. It doesn't matter. When you're running from a lion, you don't need to go, ooh, those are pretty flowers. I'm really hungry right now. You don't have somebody running from the police stopping at Chipotle because they're like, I'm going to get a bowl right now. I really want a bowl. They're just taking off, right? So generally... Yeah, not that kind of bowl. Different. They dump the other bowl. They don't want that bowl either. So, anyways, but generally you have this, those things shut off. They don't come on. So, but again, so what we found was really critical in that, of all the people I work with for anxiety, that's not generally the most effective way for them to manage their anxiety. But we found out that through body. So through that, I sent him to a physical therapist. I sent him to PT. I sent him to a yoga specialist, and a bunch of different things he can examine to try to continue to manipulate the muscles in his body to externally control his anxiety while we process through the triggers of his anxiety. So he has gotten probably 60% relief from anxiety, or 70%, just by impacting his physical muscles in his upper back and neck, which in turn, it's almost impossible to have stress and anxiety when your muscles are relaxed. So if you can force your body to relax, you can reduce that. Yeah.
Question: when it comes to treatment planning, how you have to show progress and stuff.
Mm-hmm.
How do you put numbers to those things? Don't they have to have some sort of number? Because goals have to be measurable.
Well, objectives are, and when you're doing community-based work, it's important. Outpatient, you don't need that as clearly.
Oh.
However,
you said it was like reduced by 60 or 70%.
Yeah, I'm just guessing how much it's reduced by. He can do. You can also scale. If you started off and said, "Where are you at right now?" and then I said, "Okay, now where are you now?" So in his case, he's very analytical, quirky, and so he actually bought a watch that constantly tells him his heart rate. So he will go through and say, "So last time I was in your session, last week, I was at 120. I went up to 135. I went to 180 earlier before I came in." And then when I left, I was whatever. And then I did this. I was at a 110, and then I did the neck stretching stuff, and I went down to 85. And then I was 85 when I came in the lobby today, sitting in the lobby, which is probably a little bit of white coat, a little elevated. And then I dropped, as soon as I got and sat down in the lobby, I dropped down into the 70s. And right now, and he said, I'm at about 81. So we're looking at he was at 130 last time he was in the office. And now he's down to in the 80s for his heart rate. And we do know heart rate is directly related to flooding of emotion. So you can kind of see where some of that kind of happens. So it's very interesting though, isn't it? I bring that up because of what I just said earlier, is that we use our own body of knowledge, our own experience to treat things like what it's like when we're anxious. The problem is when we start dealing with schizophrenia, more than likely you don't know what that's like. And so what their experiences can be a little bit different. Everyone's experience is a little bit different. That's one of the problems with addiction work. A lot of people before they see you, they'll say, are you in recovery? Because if you're not in recovery, I don't want to see you. Because you don't know what it's like to be addicted. And so, and I don't know what it's like to be a pedophile. I don't know what it's like to be a murderer. We can treat those things. So the problem is that somebody who does know what it's like to be in recovery, they know the way that got them out of addiction. And as long as you are compliant and congruent with their way, they can be very effective. But if not, they have one tool generally they're going to use to move that. And then if that tool doesn't work for you, you're going to say, I tried, and it's not going to work. So you're better off to find somebody who specializes in addiction, that knows multiple ways to work with somebody, motivational interviewing, 12-step, can systemically address the whole thing that you need to do to get you out of addiction. But people tend to go, I want somebody who has a personal experience with addiction. So those are the type of things you can kind of run into. One mistake many therapists make is to share their personal experience. I've had many clients come in. I have a colleague that some of you may know. That's a therapist in our area. And I had a client come in and say, I was seeing so-and-so and they were helpful for a little while and then they weren't helpful anymore. She started talking about herself a lot. I didn't know she was raped. I didn't know she was raped either. Now, apparently a lot of people know she was raped because she told her client she was raped. And now the client's telling everybody else she was raped, the therapist. So, here's a therapist that was in your seat or a different seat like it, who had a history of whatever and told the client, trying to be like, I get what she was doing. She was like, no, I do understand. I've been right where you're at. I know what you're going through. And they're like, oh, okay, like you've experienced, I feel better telling you my story. Instead of using clinical skills, they used other skills, and now this story is out about this counselor. And there's no faculty here or anything like that. I'm just saying in general. But it is a clinician in our area, in our community, that you may have seen, I don't know, or know of. But again, just a general idea here. If you really want to be careful what you're disclosing from your own personal experience. Personal experience is double-edged sword. If you remember how many take 500? Do you guys do that assignment where you have that little 12 events in your life thing or whatever? Yeah, you could see what's transference and counter-transference ability and what's, everything. That was the first aha moment for me in this program when I was like, everything I think will make me a good counselor is also an area I may struggle. I'm like, that's not very reassuring. But what it is you've got to get through your stuff and manage your stuff, and then you're able to kind of get through that as well and work with people as well. So it doesn't hurt that you have experience and you know what people are going through, but you have to just realize, always keep a grain of salt about, okay, this is my experience, what's their experience? What's going to be the best tool for them? That's why I often ask people if they were a 10 before, what got you to a 7 or a 6? Because I'm going to migrate whatever they tell me into this current story because it already works for them. I know it's going to work. So I'm going to start there at least. But I'm not going from what helped me get from a 10 to a 6. I want to see what got them there. So now, bridging into what we're talking about here with psychosis, we have a little bit of an advantage because, it's not a lot of us have seen it or dealt with psychosis. So I'm going to get and I realize I haven't posted the other PowerPoints yet either. I'm trying to make sure everything's clean on them, that you're able to do that. This is another one I want to go through just generally with you, cover some of the medical side of things as well. I want to go over that as well. So we want to look at just the broad, does anybody know what DX means? Okay, good. I want to make sure y'all know. I started using that on your scenarios. So SXS is symptoms. DX is diagnosis. There's a whole list of medical codes. If you're reading coding from another physician, they use a lot of them. You need to, someone will say QP, QM. Some of those are like medicine taken by mouth, taken by whatever, QAM, taken morning. There's different terms. There are lists of those things. It's good to know. But TX is treatment for your purposes. SXS is symptoms, and then you got DX is diagnosis. So and PT is patient usually. So you may note and say, patient has no further SXS, it has no further symptoms, or patient reported no SI or HI, suicidal ideation or homicidal ideation. Sometimes you use symbols in different things in your writing. Usually you won't, but sometimes you do, and so you need to know kind of what they are. All right. So let's talk a little bit about it. So differential diagnosis for psychotic disorders. Let's talk about the differentials first, because we're always looking for what the best fit for diagnosis is. There's mood disorders with psychotic features. Remember, when you're talking about psychosis with a mood issue or a mood with psychosis, you're looking for what's predominant. You're looking to tell the story with the diagnosis. So is it a burger with a side of fries, or do you have a plate of fries and a side of a burger type of thing? It's like, what is the predominant thing? Some people have mood disorders, and in the middle of the mood disorders, they have faint. I thought I heard somebody, but I didn't. And sometimes I see people I think are following me. They don't have a real solid history of psychosis, but they predominantly have a mood disorder, and they have some perceptions. We'll get into it in a minute. We have borderlines. Borderlines tend to have paranoia. So the paranoia can often be like, like if your client gets their ex texts them and says, "Why are you following me?" And they're like, "I was at home," and she texts while I was following her. That comes off like psychosis, but borderlines can tend to be paranoid. So it might be borderline with paranoia instead of a full-on psychotic event. Does that make sense? So you want to look at what kind of is going on. Schizophrenia and schizoform disorders, substance-induced psychotic disorder. Anybody know what that is? Pretty much. They're on a drug, tripping. So these are ones where, so you can write this down if you're taking notes. If you see a client, hear a client, have a client that suddenly has psychosis or memory problems. So if you saw them last week and they were fine, they come in today, they kind of don't know who you are, and they say, "Do you keep hearing the birds?" Are the lights dimming in here? Because I see lights flashing. Anything like that, you want to check in on substances. Did you take any, even prescription? Like, did you take anything? Yeah, my husband gave me something for a headache. What did he give you? You need to know. So I worked in a school. Some of you know. Some of you may work in schools. That's awesome. I worked in a school, and there was a girl in the clinic, and she was laying there and she was babbling, and she was like, I don't know, she's talking and just seeing things, and so it was a new girl. We didn't know her. She was a new transfer to the school, and so we were like, what's going on? What's going on? And she's like, I don't know. And that's finally I was like, look, well, we can't. I'm trying to find out. Did you take anything? Did you do it? What? And she was like, I don't know. I took a friend gave me a pill. And I was like, okay, so you took a pill from somebody. Who gave you the pill? I don't want to say. I don't know. I said, we need to know who gave you the pill, because we need to know what the pill is. Do you know what the pill was? I don't know. So I just said, let's get a medic over here. So we call an ambulance. Ambulance comes to the school, and they're like, honey, we need to know what you took. And she's like, I don't want to say. She's crying. I don't want to say you gave it. I don't know who it. And she's just babbling. And they're like, you need to tell us what you took or who. And so she's like, I don't know. And finally, the medic was just not as tolerant as I was. So he was like, let's get an IV. And she's like, no, I don't like needles. She's laying there, and I got her strapped down. And he takes the needle. And he takes the needle, and he's like, gets the line. He sticks the needle in, and she screams, Tiffany, in her last name. So I actually remember the last name, but I won't tell you who it is. but she screams this girl's name, so we knew who gave her the pills. So we end up calling Tiffany out of class, and Tiffany's like, oh my gosh, she came here. She's a new student. And she was like, I have really bad back pain. Did you have a grandparent or something that takes anything for their back? And then I was like, oh, my grandma has bad back pain. I'll grab one of her pills. And took like a hydrocodone and gave her a hydrocodone in class. She didn't know what it was. The other girl didn't know either. She was like, oh, I don't know. I just grabbed one again. So the other girl got expelled for distribution, unfortunately. And then the girl who took the pill got kicked out as well. And then she went to the ER, and the doctor was like, we'll just let her stay on the ride. She'll be fine. It's not going to be fun, though. Because they were thinking of charcoaling her or whatever. But once they figured out what the pill was, they realized they didn't have to do that. Anyways, my point is the psychotic disorders, you want to know if there's anything medical. Number 2 thing you want to write down, more important than the medical, is you want to know if it's sudden onset. You want them immediately to go to the emergency room. They need a CT scan. I can tell you 2 or 3 that have had major problems with different things. Had one, it wasn't me, it was a different clinician. Had one very recently, a friend of mine who practices. He was seeing somebody who was trying to really develop their relationship with a sibling. They had a younger child, rather. They had a child. And the child was just estranged. They didn't get along. And so parent was trying to work on the relationship. And then while 2 or 3 weeks after they started working on it, the child, who was an adult at the time, the child developed a brain tumor. And it was advanced stages and died. And so died within a month. So right after starting to renew the relationship, the client counselor's working on grief for the loss of a child who died of the brain tumor. And then a few weeks later, they continued working. They had been working for months, maybe, because I don't really know the case too well. But they were working for months, maybe, and then the parent came in and came in a day earlier than their appointment. And I was like, I know it's at 11 o'clock today. And they said, no, it's 11 o'clock tomorrow. And they've been coming the same day the whole time. Just disoriented, finally came in. They're like, what's going on? And I don't really know. I don't know why I didn't. And just didn't know facts, didn't know things that were going on. The clinician sent immediately to the emergency room. You need to go to the emergency room. Found out that the person that went, the parent had a stage 4 brain tumor as well. So a few months later, now terminal brain cancer, and so now they were processing. The clinician was now processing not just the grief of the loss of their child, but now their own death, and that was all within 3, 4, 5 months. Can you? I mean, that's what you signed up for. So for work. So just a heads up.
Yeah.
So, me too. You walk through people's pain, you're going to deal with this stuff, but you can imagine, though, if you have symptoms that are sudden onset, you want to do something, you want to see what's going on in the brain. Some of the things that are going on can be reversed quickly. I've had numerous patients who've had lights flashing, things going on, and remember, 60% of the brain is vision. So if they have visual perceptions, things like that going on, they need to see a neurologist, and you want to see them signed off. I've had a number of neurologists call me and say, hey, good catch on that. They have lesions in their brain, or they have MS, so we caught it early. So there's things going on in their brain, tumors, different things going on, cysts. One of them had a cyst. It was benign, but it was a cyst, and they're going to monitor it. But now I'm not just trying to do, what kind of, maybe you're schizophrenic. It's really more of like, okay, there's something, the sudden change is the big indicator. If they have had schizophrenic symptoms since they're 14 years old and they're 52, that's not necessarily a brain tumor, right? So if any sudden changes in perception, things like that, you want to make sure they're getting to a medical doctor. That is critical. So delusional disorder, psychotic disorder due to general medical condition. Again, cysts, lesions, these things in the brain are going to affect their perception. They're going to affect the way they can handle things. And so you're going to want to make sure they get into something where they can figure that out a little bit. Shared psychotic disorder. Psychotic disorder, NOS, they don't really use that as much anymore, NOS, but that sometimes people, they're going to be an unspecified psychotic disorder. You're going to see psychosis and go, I don't know what exactly kind this is, but I want to, see what we can do. So, delirium. Patients often have paranoia and visual hallucinations. So if they're delirious, if they're experiencing delirium, That is a different diagnosis. This is where it gets tricky. If it is paranoia and hallucinations, they may be having some kind of delirium. Paranoid personality disorder and schizotypal personality disorders can come very, very close to psychosis. Again, we'll get into this personality disorders a little bit later. And obsessive compulsive disorder at times can be very difficult to discern from psychosis. They are so active at managing the compulsion in their brain, or their obsession rather, that it can come off as psychosis. I told you about the lines in the carpeting from vacuuming. You know, if you're like, the lines aren't there, they're messed up, and you're sitting here going, this looks like a showroom floor. You know, you may think they're psychotic, right? But it's really the OCD and the compulsion, not as much the breaking reality of psychosis. So that's where you really want to monitor things. Now, I also want to say this. If you're getting into a psychotic disorder, take your time, okay? Like, just pay attention to what's going on. You don't have to throw down the perfect psychotic disorder to diagnosis the first 45 minutes you meet somebody. All right, so it's tricky. It could be a lot of different things. And if you see a certain side of something and then you get the other side of it and you're like, okay, I need to do X, Y, Z instead, you know, and you see something a little bit different, you can change the diagnosis, that's fine. Or you see paperwork from somewhere and a doctor does something different. I've had patients go have adjustment disorder, generalized anxiety disorder, and then all of a sudden they go off the deep end, they get drunk, they want to drive their car into a tree. My patient, wife calls 911, they end up going to a psychiatric hospital, and they get some diagnosis of major depressive recurrent with psychotic features or something, and you're like, where was that? And you feel stupid because you're like, that's not what I have down, But they saw a different picture at the psych hospital. So you got to kind of look at that and go, okay, so that's what they're being treated for there. And you can amend your stuff. But if you still don't see that day to day, you don't have to write that in your chart. And because anybody who reads an auditor, these people, or somebody down the road sees the whole chart, they're going to see what goes on. He had a breakdown, whatever, this is what happened. So you want to see something over time. So when dysregulated, borderlines can appear paranoid. They'll think they hear people talking about them. They'll think people are following them. They have this very frail sense of self. One thing borderlines love to do is they will create a hurricane and hide in the eye of the hurricane. And so what I mean by that is, now I figured that out because I was in what's called grand rounds when I was the director of a psych hospital's intake department. And so what they did was, I had a very, very good psychiatrist say, okay, who's coming in next? And we pulled out the chart. Susie, so-and-so. Okay. He says, Susie's going to come in here and she's going to create a storm, like a hurricane, and she's going to hide in the eye. And so she's going to create some kind of drama so we don't get to anything personal about her that can hurt her. So she's going to try to get us caught up in the exterior storm she creates. So her fragile sense of self does not get wounded. So she's going to create a decoy scenario for us to address. Okay, let her in. They open the door. She comes in. Oh my gosh, Dr. So-and-so. Oh my gosh. You won't believe what happened. They took my shoes last night. Oh my gosh, she's crying. The nurses took my shoes. They can't believe it. You got to get my shoes back. They told me I was going to do it. And we're just sitting there going, he totally nailed exactly what she was going to do. And so he let her go for a minute, then he totally sidestepped and went right in and was like, I'm not worried about the nurse or your shoes. Let's talk about this. And we're just like, boom. So he wasn't the best bedside for a psychiatrist, but he was really, but we didn't get caught up in, let me see what I can do. Let me see what I can do about the shoes. Because she would rather you talk about the shoes, that's fake, than to address really what's going on inside of her. So borderlines tend to do that. They have a very fragile sense of self. The other thing they do, we know they vilify. In other words, they'll be in a relationship. Oh my gosh, this guy is the best. I've never seen a guy this good. He is absolutely the best. Then if things go bad in their life and the best thing they can do, they can't admit it's me. They can't go, I'm really having trouble. And you'll know that's one of the big kind of indicators. It's not I don't think it's the big indicator, but if they have insight personally, they're probably not borderline. Generally, if they can come back and go, I'm really struggling with this right now. You need to relook and go, maybe they're not borderline. But if they come in and go, look, look, I can't believe so-and-so treated me this way. I mean, I would put up with his abuse for too long. And you're like, last week he was the king of the world. Now he's abuse, and how long have you been putting up with abuse? And then they're like, you don't know what I lived through and stuff like that. I act like this, he acts like this and whatever. So they're going to kick him out of her life. She's going to say, get him out of my life, and then my life will be okay, and I'll just start over. And what they don't want is people around them who challenge that. So they get rid of therapists frequently. So what they'll do is they have all these enablers in their life who are like, you go girl, absolutely. And they just get behind them of like, and they're like, I don't care if you're right or wrong, I just want to be your friend. And they're like, good, because we need to be each other, we need to have each other. So they're really close until they kick them out of their life. So you'll see, I know two daughters raised by the same mom and dad, obviously. Mom was bipolar, severe bipolar. Dad was a Marine. Siblings were very, very close, matching tattoos, all that kind of thing. Because siblings, borderlines are really close to their siblings usually, because they grew up together. They didn't really have as much access to parents. So they can have really close bonds to siblings sometimes. But what they did, both daughters married, divorced their husbands, remarried their original husbands, divorced those husbands again, and remarried. So they were all married 3 times to the same men. Because he's a villain. Then, he was the best thing in my life. I was all wrong. But when I get him out, he is just destroying my life. Oh, he was amazing. They did it 3 times. Both of them did it 3 times, like together. So they'll see that. They'll also be like, oh, mom is wonderful. I'm spending so much time with mom. Then it's like, I don't want anything to do with her. I'm not answering her calls. She is crazy. Don't talk to my sister. Okay, we'll talk to she's amazing. I support her 100%. And so they have this, people can't be good and bad in their life. They're either good or they're bad. And then they flip the switch. And so they can't internally go, hey, I'm having a hard time. So they're like, I'll get that person out of my life and I'll relocate and go here. I'll get a new job over here. They want to switch everything externally to try to cover up their dysfunction personally, thinking nobody notices. And that's why borderlines by their trail of relationship fracture. They cannot maintain close relationships. They constantly struggle with this push-pull. And so, yeah.
I was going to, if I can, offer perspective.
Sure.
Hope, where my sister has borderline.
Yeah.
And she's been in treatment for around 10 years now.
Good for her.
And she is developing a lot of insight for herself. So there is hope for people who have.
You know what? It's interesting because 5 years ago there wasn't. If you wrote down borderline personality disorder on a chart, you couldn't be reimbursed because it was incurable. That's what they said. But with DBT and a lot of modern treatments, there's excellent treatment for borderline personality disorder. Mm-hmm. Yeah. So
I'm laughing over here because a lot of what you're saying with the relationship hurricanes and everything is very her.
Yeah.
But she works in mental health advocacy too. So
good.
She's on the right track for sure.
That's so cool because if they get involved in therapy, that's the hard thing is that most of them won't admit they have the diagnosis for even looking at and going. At some point, if they do get to this aha moment of what is going on with me? I always find the wrong man. Why? What is it with me that I'm always finding, or whatever? And then they get into realizing, hey, here's what's kind of going on. There's also a lot of research that says they receive treatment better if you don't tell them their diagnosis. So, and that's true of all personality disorders. There's some really neat research out there on how much should you disclose about somebody having a personality disorder. Now narcissists tend to think and know they're narcissists. They really, that's a badge of honor. So there's a therapist, I think he charges $900 an hour in Washington, D.C., and he treats nothing but male narcissists in D.C. So there's a few of them up there. And and apparently this guy makes a killing just doing nothing. He just sees nothing except cash pay narcissists.
Wow.
Of course, if you are a narcissist, you're probably that's right, man. And I got the bank, so I'm going to beg. There's all this pay. I'll pay $900 a week to see you, sure. And they don't care. But I mean, something ridiculous like that. But the guy's that's supposed to, apparently, only reason I know, someone told me about him, and I kind of wanted to connect with him. So I'm like, what are you doing to treat narcissists that well? That's pretty amazing. So someone told me he's also a recovering narcissist, but I don't know. That could be fictitious. demands $900 for his services. So maybe he is. I don't know. Maybe he's very, very exaggerated, inflated of his value, but who knows? I don't know. But anyways, yeah, personality disorders were thought to be incurable years ago, and now DBT and a lot of the new things that are out there of mindfulness are really, really working well to help people, kind of get some handle on that too. So very, very cool. In fact, interestingly, there's only 2 practices in Virginia that specialize in DBT. And by specialize, I mean they've gone to all the national trainings, they do coaching, they do train the trainer from the actual association of DBT. If you go on the website for DBT official therapists, there's only 2 practices that have them. One of them is in Richmond, and the other one is run by Dr. Savinsky. So Dr. Savinsky is the clinical director of Regent program here. So his wife is one of them. They have beach counseling and consultation, I think it's called, in Virginia Beach, and they run groups for borderlines, and they treat borderline personality disorder, and they're excellent at it. So it's just interesting, and they're willing to train people and kind of get them up to speed on that, and take you to the trainings and kind of get you certified in it too, if you want to do that. Most people, if you go to conferences and stuff, they're going to be like, "Ooh, I had a borderline this morning." And that's not like a breakfast cereal. That's like really like, that is like, I had a draining, that's like therapy for, I've had a really draining morning. Sometimes you don't realize you're seeing a borderline until you're done, and then you're exhausted because it's like you're just doing laps around the therapy pool, and you're like, man, I am exhausted from this. So working with borderlines, I could never do a full patient load. It is just too draining working with personality disorders. There are so many moving parts and things going on that it is really, really difficult. So it's good if you're going to treat it, know what you're doing with it, because they may only give therapy a shot once or twice. So you want to make sure you're there, that you can really do what you can do on it.
So DBT, that's dialectical behavioral therapy?
Yes.
Okay.
Yeah. Anyways, so how do we figure out to diagnose this? That's an awful picture. Okay. So are psychotic symptoms only present when mood symptoms are present? That's what you kind of want to know. Because if it's not a consistent psychotic presence, but it's primarily present when there's a mood issue present, you're probably looking at a mood disorder with psychosis. Does that make sense? So when the mood symptoms are triggered, there's psychosis with it. If they're psychotic all the time and then they have a bad day and they have a mood, then that's a psychotic issue, then they had a bad day, right? So that's how the difference is. You kind of which one's coming first, what's coming together with it. Does the patient have a medical condition that causes psychosis? You're going to need to do that. If you see anybody with psychosis, they need a full medical examination and workup. You got to make sure they get something done. You want to see something from their primary care. You want to get a signed release of information, and you want to connect with that medical provider one-on-one. Don't just assume they're going to leave your office and know exactly what you were thinking. So you're going to want to talk to that medical provider and say, hey, I really need to see some kind of psychological workup on them. If you would see them, I observed this and this and this. They had some psychosis, a little concerned about what's going on here. I'm not sure if you've seen this before, how long you've been treating them. But that doctor will then thank you and refer all their patients to you, and will also make sure they do the medical part. You can collaborate care. Does anybody know what this is? It's the chemical breakdown for alcohol. So if you ever see that medical charts, ETOH means alcohol. So drinking kind of alcohol, ethanol. So if you see that, that's what that stands for. People write it in codes all the time. You'll see it on the intake of Virginia Beach Psych. ETOH 13 weekly, 13 drinks of alcohol per week, 3 to 5 daily. They have 3 to 5 drinks of alcohol per week, or day rather. If yes, they have symptoms present after at least 1 month of sobriety. So if they have an alcohol problem, they could have psychosis. If they are coming off of alcohol addiction, they can also have psychosis and delirium. So they can be delirious from alcohol withdrawal, or they could be drunk. So if you have slurred speech, where's that coming from? It's coming from their muscle response. The brain is telling the lips to do something, and it's slowing, so you have a depressant. So you're generally, when people are drinking and they slow their speech and they can't speak, it's because the depressant is slowing the muscle response a little bit. So if you see some slurred speech, or they're stumbling in their gait when they walk, that's not necessarily psychosis. You're looking for substances. What else is going on? I've had patients that have had trouble with that before, and not smelled any kind of alcohol, knowing they're not taking medication, and found out they had sent them to a medical evaluation and found out they had some neuropathy. So their B12 was not absorbing into their intestines. And so as a result, their nerve endings were losing feeling in their feet. So they were stumbling in fingers and mouth. They were having trouble with symptoms, but it was from neuropathy, from a mineral deficiency, and not from anything psychological at all. So these are all the things that we're not trained to really look at, that you really want to put another set of eyes on. You don't want to be the one holding the hot potato. We talk about hot potato? Good. Let's talk about hot potato. Let's talk about being sued. So when you're sued, there's 3 questions you're going to have to answer. So you're going to want to know these. 3 questions you will answer when you are sued. Number 1, what did you know? I should say I'm not a lawyer, too. But I traveled with a lawyer around the time of Columbine, and we traveled all over the country together, and he gave his presentation to school principals. And so, specializing on this. So that's why I'm telling you. What did you know? Number 2, when did you know it? You want to write this down? I know you do. She was in my class last semester and she heard all this. Can I tell everyone? Okay. And then number 3, what did you do about it once you knew about it? So, client calls you and says, oh my gosh, I think I'm going to kill myself. And you're like, well, come in Tuesday. I have an opening Tuesday afternoon. And then they don't come in and you find out they killed themselves. They're going to come back to you and go, their wife will say, her husband, call their therapist. So they're going to get a hold of you and they're going to look at their phone, her phone, your phone, and say, what happened? What did you know? I knew she was suicidal. When did you know it? I knew at 9 o'clock last night. What did you do about it? I told her I'd see her on Tuesday. And then they're going to say, is that the best practice for a clinician? Is that the best advice? No. Same story. You get a phone call 9 o'clock at night, and you're like, someone leaves a voicemail, I think I'm going to kill myself. You call them back. You star 67, dial their number so they can't see your number, but you call them back and say, hey, listen, if you're serious about this, I need you to go call 911, go to any emergency room, call 1-800-SUICIDE. I'll see you the first thing in the morning when I can. I'll get to as soon as we possibly can, but I need you to get someplace now to make sure you're safe. Same story, morning, you set a point, you tell them I have Tuesday at 2 o'clock. Tuesday at 2 comes around, they don't come in. You call the husband says she suicided last night. What did you know? You knew she was suicidal. When did you know it? 9 o'clock last night. What did you do about it? You called her back at 9:15 and told her to get to critical care, someplace safe for safety as soon as possible. That's the best practice. You couldn't have done any more than that. So those are the questions you're going to answer. So in general, you're not responsible for things you don't know. And you need to make sure you're acting within the best practices of what you're doing. You get in trouble with other things, like somebody leaves a voicemail for an appointment and you don't call them back for 4 or 5 or 6 days. They reached out to a therapist and you didn't call back. I strongly recommend you call everyone back every single day. Even if you don't have room for them in your appointment. Hey, I just want to reach out. I don't have any room for you right now. Have your office call. Have somebody call. But you don't want to be like, I had a voicemail. I knew they needed help. I didn't respond. They're dead. Not a good thing. So, anyways, just to make sure you have those things, you understand them in general. But again, that's what you need to know. Hot potato is, You don't want to be the last one holding the hot potato when something bad happens. So if you get information of like, oh my gosh, you're slurring your speech, they're walking funny, something's going on, don't let them get in a car and drive home. Call 911 right then. And if the medics say, well, I'll let them drive home, who's liable? Not you. Yeah, but you don't want to be the one that had the information. I saw she couldn't stand up. She fell twice going down the stairs. What did you do about it? Nothing. It's not my job. Then she got a car and she got hit, injured herself or whatever, ran over a child. So you want to make sure you are covering yourself by those things. And so if there's something medical and you're like, I don't know what's going on, get a doctor involved. Get as many specialists involved as you can. Why do you think we talk about the Lupron shots? Because that doctor doesn't want to be the one hanging when something happens with the Lupron shot, right? They want another name on there too. It said multiple professionals collaborated and agreed that this was a good decision. That's what your job is. You're the multiple professional. Or whatever decision. You want to have multiple professionals in major decisions. And so if you see symptoms that are outside the scope or could be critical, get them help right away. Very, very important. Does the patient have prominent negative symptoms? Is the patient delusional or psychotic? What is the nature of the psychotic symptoms? Are they mood congruent? Depressive themes associated with psychosis, mood congruent. So congruence is a big deal. When people are not congruent, there's the problems usually. If someone's excited about something bad and they're happy, oh my gosh, I'm so depressed yesterday, you wouldn't believe it. You're like, okay, well, you're really happy right now. Like, what? Why the incongruence? So again, what are the nature? Are they congruent? So are they? If the psychosis is going on and they have themes of voices telling them to jump out a window, that's going to be a little bit different, than whatever they may be seeing too. And keep in mind, some substances they may take could be in their system for long periods of time. So just a heads up on that. Hallucinations are defined as false sensory perceptions not associated with real external stimuli. That's the definition. False sensory perceptions not associated with real stimuli. I walk down the street and I see a man in a black suit following me. He could actually be walking down the street, but there is nobody wearing a black suit following him. If they're walking down the street and they saw they saw a small man in a football uniform following them, and there was a little boy standing outside waiting to go to football practice in his uniform, that is not hallucination. Okay? Even though they weren't following him, you could see there's a real thing there that could have been confusing. So that's what you're kind of looking for. They're chasing me. That's a bad thing. I think I've already told Keiko this story, but for the rest of you, I think it's only fair and therapeutic for me. Do you mind if I have a therapeutic moment? Okay, good. So when I was in law enforcement, I ran into many people who were psychotic, and I'll tell you about two of them today. One of them first, though, I was actually not having a good day. I was having a fever, I had strep throat, but I was working midnight shift, and I was patrolling, and I was driving down the street, and I saw somebody that looked like the wrestler Kane. You guys know anything about wrestling? Kane, big giant, 7 foot tall, big. Yes, Kane. And I saw the guy driving a car looking really suspicious, and I was like, what is going on with that? Something's wrong with this guy. And so I slowed down a little bit and I ran the license plate, and he came back suspended in the state of Kentucky with 13 warrants on file. So he was a fugitive, and as soon as I ran the license plate, he turned a U-turn. He had a very, very fast car. It was like a 69 Chevelle. It was an old, fast car. And so at that point, I turned around and began to pull him over, at which time a vehicle pursuit ensued. And so now we're going 120 miles an hour through the city, and I'm calling it in. My nearest backup was probably 8 miles away. And so, now I should say, I was at the time on the way home because I was sick. And I lived in a neighborhood that's called, I lived in a neighborhood in Newport News called Kiln Creek, if you're familiar with Newport News. And my parents lived in Kiln Creek in one of the big houses there. I lived in the townhouses. And so I lived a block over from my parents. We had a little 1-year-old baby, and it was like really convenient. And it was a nice little starting home thing. So I was coming home, and he cuts into Kiln Creek. And so now he's going down Kiln Creek Parkway at very, very high rate of speed. He turns around, starts heading back to Victory Boulevard, and then he cuts in a neighborhood. At the time, there was a business there called Cybernetics. It was a big office building, and there's some woods on the corner. So he tried to get around the building of Cybernetics, but it was an underground parking garage. There was no place to go. So he slams on the brakes, gets out of the car, takes off running, and he was about 7 feet tall, and this giant dude. So I'm already like, I have a fever, I'm sweating like a pig, and so we're running around the side of the street, and as soon as he hit the tree line, he just disappeared. So I come to the wood line, and I'm like, okay, so I pull out my gun, and I have my flashlight, and I'm looking for this guy, and I'm going really slow. And sidebar on the story. My dad was a chaplain. He was a minister, and he was a chaplain for the department. And so he would often ride with me. He wasn't riding that night or ride with one of the other deputies. He was at home, but he would listen to the scanner when he was at home. So back to the story. So I go in the woods, I have my gun out and the light on, and I see him behind the bushes hiding there. So I tell him to get on the ground. He figures, oh, well, I'm caught, stands up. Now he's huge. I can hear the sirens coming of my partners, and I see them, they're like, where are you? And I'm looking, I'm like, I'm in the woods. And they're like, we don't see you, where are you? And I see the cars kind of going back and forth around the wood line. And this guy gets up, and then, so I do the police thing to apprehend him. And then we're on the ground fighting, and I have one arm, and I'm not letting go of this giant's one arm, okay? That's all I've got. And my radio's up here, and my hands are here. And they're like, we don't see you, where are you? And there's like no response, because I'm not talking at this point. There's nothing to talk about. So I see somebody's flashlight at the side of the woods, and they're really close. They're like, that trophy case. And so I get off and I put my flashlight so they can see where my light is. I see the guy kind of running through the woods. So now the guy starts to get up off the ground again. And then we go take him to the ground, and we reapprehend him. We get him. I'm covered in mud. He's covered in mud. I got a fever. And so I walk out of the woods, and I go back to my car, and the other police car that's there, and he's like screaming the whole time, snakes. Watch out for the snakes. There's snakes. He's completely like tripping. And so I thought he was under the influence of a drug. I charged him with driving under the influence of drugs and several other things. And so I get him there. I get into the car, and this is the therapeutic part. Out of nowhere, it's 2:30 in the morning. We're in an industrial neighborhood right by this little building, and a green car come in, and it's my mother. It's my mom in her pajamas, driving along, checking on me. And there's no one there but police. And finally the other deputies are like, is that your mom? And she's looking at me like mad, and then she's like, don't. So she leaves, and then she said, don't you ever chase somebody like that in the woods again. That guy you're lucky you're alive. And I'm like, thanks, Mom. I really appreciate your belief in my training in physical fitness or whatever. So I got yelled at by my mother on a call in the woods with all the police around. So it's therapeutic. That being said, I took the guy to court, and while he was in the holding cell, you could hear him in the court screaming, snakes, you're eating me, snakes. So obviously he'd been in jail for like 3 weeks and still screaming about the snakes. He was not under the influence of drugs. I lost the DUI. But he was hallucinating and was having a psychotic break. So who knows why he's running from the police? Because who knows what he thought I was or who I was. But he was completely psychotic even after 3 or 4 days, or 3 or 4 weeks of sitting in jail. So, but anyways, that's my therapeutic story. I have another one. You want to hear that one real quick too? It's also a psychotic story. Okay, I received a call. I was actually, and those of you who don't believe in the full moon, that's a real thing. Okay, so it was a full moon, and I was at someone's house who had the windows and the air conditioning covered with plastic. And I went in there and checked on a frequent flyer guy who struggles, and he said those aliens are back trying to put stuff into air conditioning vents. And it's hot. It's like 90 degrees in the house, stifling hot. And he's like, they put stuff in there. They keep trying to poison me. And I'm like, okay, that's not. I saw him walking through the yard, and I'm like, it's probably Virginia Power. I don't know what's going on, but are they there now? No, there's no one. So I'm talking to him. And finally, dispatchers call and said, can you clear there? And I'm like, what do you got? There's another officer there. And they said, we need you to call in on your phone so you can hear the 911 call, which is really rare. So I'm like, okay. So I call in, and there's a guy on the phone, and I don't remember it exactly, but I'll tell you the part I do remember. 911 says, this is 911, what's your emergency? He said, I have the code to save the world. They said, 911, what's your emergency? They said, I had the code to save the world. Yellow, blue, gold, 932-936-5552-355, and he gives this code. Now they hung up or whatever, and he called back again. He goes, I have the code to save the world. Yellow, blue, gold, 95523. It gives the exact sequence of like 29 numbers. So they're like, they're saying, can you go? He's at a payphone at a hotel. So I'm like, okay. So I leave the air conditioning guy. I go over here. Incidentally, this is in Williamsburg, where Eastern State Hospital is. So just a heads up, people like get out. Sometimes they don't go into the middle treatment areas. They just walk around. But he gets out there, and I'm like, I'm in the hotel, and I'm like, did you see somebody using the phones? And they're like, no, we didn't see anybody. It was kind of busy in the lobby, and they call on the radio. They say he's right next door to your location at the payphone at the gas station. I go back out to my car. I drive around to the gas station. I see somebody on the phone. I just keep him on the phone. I pull up, and he's talking. I said, tell him I'm behind him. So they tell the officer's here. So I see the guy, and I'm like, hey, what can I do for you? He goes, I've got the code to save the world. I said, well, where'd you get the code from? He said, Swordfish Hammer gave it to me. I said, who's Swordfish Hammer? He said, that's their code name. I can't tell you. So Swordfish Hammer gave you the code. Who gave Swordfish Hammer the code to save the world? Jesus. Okay, so Jesus told Swordfish Hammer the code to save the world. Okay. So finally I was like, I didn't know what to do. But I wasn't trained like y'all, okay? So just heads up. So I was like, this is bigger than you and me. That's what I said to him. I said, I can't save the world. I just drive around a police car. But I can take you to the person who can. And he's like, okay, so I said, we need to go see Sergeant Green. Sergeant Green has all the connections to save the world. And he's like, let's go. So he's just on a mission, walks over to my car. And I said, I'm going to have to put these handcuffs on you. He's like, whoa. And I'm like, look, are we saving the world or not? Because if we're not saving the world, I'm leaving, But if you want to save the world, this is my policy. You want me to get fired for saving the world? Okay. So he gives me a rip. So I handcuff him, I put him in a car, and I'm taking him I'm driving him up the road. And so, true story, all this is completely true. And so finally, I was like, if I'm going to save the world with you, I think I should have a code name too. And he's in the back, and he looks at me and he goes, you're going to be Big Daddy. So no lie, I was like Big Daddy. Big Daddy's en route to the jail for the pre-screener. So pre-screener, walk in the door to the pre-screener. He's like, oh, this is so-and-so, knows him by name. And he says, apparently this guy's famous, that he was actually taken into custody because he was on a PGA tour. And so what happened was he actually bought a shirt. He had one made up that said ABC Sports. He went to like a embroidery place, got a polo shirt made, and he just started traveling with them. And he'd go to hotels and say, put it on Phil Mickelson's tab. And they'd be like, okay, so he was eating meals and living in these hotels, and he followed the tour. But so what happens is he's at Kings Mill, and one of the guys, like Phil Mickelson or one of these guys, was putting. Every time he'd putt, this guy would stand there, and his only read, he would just go, miss it, 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 miss it. He would chant, miss it. And so finally, during on ESPN, you would see there was some ruckus in the crowd, and they were like, everybody, and the announcer said, everything's okay. Phil Mickelson had a stalker, and the security has apprehended him, and everything is under control. They said that actually on ESPN. So this guy actually got arrested like on ESPN and put in Eastern State. And then when they thought he was safe enough to let him out, they let him out. He had the code to save the world. There you go. Okay, so that's my psychosis stories for now. But again, yeah.
Okay, those two stories. The thing that I'm wondering about is with those hallucinations that they had with both people, they had some sense of reality in both. I mean, if he knew enough to get a shirt embroidered and say ABC, he knew seems he knew the difference between
Yeah.
right and wrong, what he was doing. And the same thing with the big guy, Kane, that he knew he was running from the police.
Mhm.
He knew where to go. If I run into the woods, he might lose me. So
Yep.
it's like, is it a fine line, or I don't understand how, if they're hallucinating, why is everything not mixed up?
Yeah, it's hard to tell because sometimes they have distinct breaks in reality. They have very distinct breaks. I worked with a guy once. I worked in his house 10 hours a week, so mental health skill building, and he had extreme psychosis. He was actually on a bridge trying to jump, and the police came. One of our local police agencies came over to him, started talking to him, and the voices said, "The police are going to kill you. You better stab yourself first so they don't torture you." So he took a knife and started stabbing himself. When the police wrestled him to the ground, took him to the psych hospital. He got out of he has big scars from his punctured lungs. Then they went ahead and took him into custody. So I saw him after that, but he would still, he would tell me, the voices are telling me things that are no good. They're telling me it's no good, Dan. I know what they're telling me, it's no good. And he could actually, he heard voices. He also had olfactory issues where he would smell. He said he smelled of rotten cheese and open wounds is what he would smell in his senses. But he was he was my first guy I ever worked with clinically. So my goal was to break him of his psychosis. My whole plan was to tell him that's not real and that he would get it. And he never did get it. Okay, so I switched to CBT and I started saying, but you're okay. But you have your own apartment, you're managing your life, and you're okay. And so by the time I left working with him, he'd say, these voices are telling me something's no good, Dan. No good. I'm not listening to them because they're up to no good. I know that, man, I'm never going to listen to them. They're up to no good. And I'm okay. Because I can do this and I can do this and I know I'm okay. So he could attach a new pattern of thinking to his psychosis that made him pretty highly functioning by the time I finished working with him. So I never did change his psychosis. He was also very, very interesting too, but he does know some reality, but there was some breaks there as well because he used to like to go to Wendy's. I'd take him to Wendy's every once in a while, same Wendy's. He always wanted the same Wendy's. And I could never eat with him. He would never let me sit across from him when I ate. He wanted to sit by a table by himself. But what was funny is he always thought everybody who worked at Wendy's names was Wendy. So he was super loud. So he'd go in Wendy's, he'd be like, "Hello, Wendy." It's like that, And everybody, they'd be like, "Is something wrong with it?" But he literally thought everybody was Wendy. So he knew he was in Wendy's. He had the reality there. He knew what food he wanted to order, but he had certain quirks that were just breaks. So I have no idea why. Couldn't begin to tell you. But there were very specific things he had struggled with. But moving on, hallucinations are defined as false sensory perceptions, not real stimuli. Delusions are false beliefs based on incorrect inferences about external reality that is firmly held despite what everyone else believes and constitutes incontrovertible, obvious proof evidence to the contrary. So, delusions are things that have some reality that they don't have the common belief. Like, they may have a belief about something. A hallucination is completely like there's a bicycle. Why is the bicycle hanging in the middle of the room right now? Well, there's no bicycle, Now, a delusion would be that machine is flooding the room with poison. There is a machine hanging there. It's a projector. And it is, everyone in the room can look at it and go, that's an LCD projector, probably not flooding the room with toxins. So that's a delusion. They're taking something real and they're demonstrating that they have a belief about it that is pretty irrefutably incorrect. That's delusional.
So they're taking something real and attaching a false belief to it.
Right. Is a delusion. Always keep in mind cultural norms too. You'll find people who have different beliefs about different things culturally, different things they've grown up with, different things like that too. We really don't have any time to get into speaking in tongues or any of that, or visions, or any of the things that are in the Bible that could be attached to any of this too. But that's a whole other thing of what people may think of what's going on, how that would be perceived by somebody through these lenses, of what God's doing or God's presence or any of those things. So that's why I say watch your cultural norms. If people get involved in some kind of a thing that's culturally, for some reason, what they believe, that's maybe something different than a delusion. Mood incongruence. Mood incongruence themes include delusions of control, persecution, thought broadcasting, thought insertion. This is where you get into your projection. So things that are not congruent with a mood, and then mood congruence is delusion, hallucination, consistent with themes of mood. Personal inadequacy, guilt, disease, death, deserved punishment. They may go, oh, it was like they were in a car accident and somebody stepped out in front of the car, got hit and killed. The person should not have been in the road. It was not a crosswalk. A mood congruent delusion might be, I'm going to spend the rest of my life in prison. I deserve to be executed since I took a life. Those may be delusional thoughts from the trauma that are not really, but that's consistent with what happened. Does that make sense? Mm-hmm. It's consistent because they were involved in a traumatic accident where someone died and they believe they're guilty. They have this level of guilt with it. You're going to find people have these delusions right after events where they're trying to find which ends up. They're trying to find out what the norm is, what's going on. So you'll find delusions in those areas, where they go through something. I deserved it. I really deserved to be divorced. I really wasn't a good husband. Like, well, why? What? And, so you get into that. People can try to rationalize things with delusions. Mood incongruent themes are ones of control. Again, thought broadcasting and thought insertion are big ones too, where what somebody else said. I know they were doing this. Psychotic illnesses. Let's talk about these. Mood disorders with psychotic features, major depressive disorder, bipolar disorder, manic, schizoaffective disorder. These are mood disorders that have psychotic themes to them. They're in the DSM. There's a lot of them. Major depressive disorder, MDD with psychotic features. Major depressive features here, psychotic symptoms while depressed. That's your key. If they only have psychosis while they're depressed, and when they're sitting in your office and they're feeling fine, they don't have them, you're looking at a mood disorder with psychosis. Does not have psychotic symptoms during regular times. Psychotic features occur 18.5% of patients who are diagnosed with MDD. Almost 20% of people, 1 out of 5 people with major depressive disorder, have some sort of psychosis with it. So it's far more prevalent than you probably think it is. You may not even ask questions about it when you realize somebody's depressed. Cortisone treatments, antidepressants, antipsychotics. You'll notice sometimes people prescribe antipsychotics for depression, and that and sometimes they work really well too. You may also find that people for anxiety can sometimes prescribe muscle relaxants. We already talked about that. If someone's muscles relax, how can they remain anxious? So sometimes they can affect the body and still impact the emotions. Those are also more addictive, so they don't like to do that. But you may see it sometimes. Psychopharm lectures on how to deal with that too. You can see a lot of those as well. ETT is a very effective psychotic depression in elderly and pregnant. So there is some ECT electrotherapy that can be very effective. You'll also find there's some magnetic treatment. You'll hear it on the radio sometimes of with this magnetic therapy we can treat depression. There's all kinds of things people want to use. Bipolar 1 with manic mixed psychotic features. A patient has bipolar disorder and is manic with some psychosis. 25% of estimated of people with bipolar 1 have some kind of psychosis. Mood stabilizers, antipsychotics, we're not going to get into that. Schizophrenia. We know the Beautiful Mind movie as well. There's a lot of good examples of schizophrenia in movies as well, but 2 or more of the following present for a significant period of time during a 1-month period. So, significant period of time during the month. Delusions, hallucinations, disorganized speech, grossly disorganized catatonic behavior. Catatonic is just no response. They just sit there and stare. Like Norman Bates' mother type of stuff, kind of like, if that were real, like someone who sits in a chair and stares, they could be have schizophrenia. Negative symptoms are affect flattening, apathy, those type of things. Only one criteria of delusion or bizarre hallucinations consistent with voice keeping, a running commentary, or 2 voices talking to each other. So again, you're looking at that. Most cause significant social occupational dysfunction, continuous signs of disturbance. My client who says they keep talking to me. He literally, when he's resting and he's sitting still, he'll sit in a room with you and go, oh, can't hear. He's all under his voice, even though he's not talking to you. He's talking to the voices. He's having a full conversation going on. You'll see people often, oceanfront. If you go to the boardwalk, you'll see people kind of having conversations with themselves. I mean, that's what they're talking about here. Continuous disturbance for 6 months. Again, you have a different thing going on completely. Paranoid. Preoccupations, one or more delusions, frequent auditory hallucinations. They're paranoid. You're looking at a paranoid schizophrenia. Disorganized speech, behavior, flat, inappropriate affect are all present. So they just have bizarre features, kind of out of nowhere. They have these different facial expressions, different things. They're more disorganized. Catatonic, motoric immobility, or excessive activity. So if they're just kind of having random motions and different things with it, extreme negativism, particular movements, you're looking at more of a type of catatonic diagnosis there. Schizophrenia, 1 to 2% of the population is affected. One of the schizophrenia capitals of America is Hampton, Virginia, in case you're wondering. So if you want to, do you know why? Anybody have an idea? The VA hospital specializes in it. So they may have a lot of people from the military that are sent to that hospital that would specialize in schizophrenia. I had a client that was 57 years old, or when I saw him, and when he was 14 years old, of course, if he's 57, now he's probably 65. So when he was 14, how many years ago that was, he was actually put in Eastern State for schizophrenia as a teenager, and he stayed in there until he was 28. He was in Eastern State Hospital for 14 years trying to be treated for schizophrenia. So, crazy. Onset symptoms, peaks 17 to 27 typically. Onset in females, 17 to 37. So when you first start seeing symptoms, pretty rare to see it before 17. 10% of new cases have onset after 45 years. So, studies, 50% of schizophrenic is related to genetics. 40 to 50% of concurrence among twins. Huge genetic component to schizophrenia. Estimated the other 50% due yet of unidentified environmental factors. So they're trying to figure out what they're exposed to in utero, or different things that may have affected their diagnosis as well. So looking at maybe neurodevelopmental proceedings and different things too. Addiction, 47% of met criteria for alcohol abuse or drug addiction. Not uncommon for people with any kind of mental disorder to try to treat it themselves. Odds of having alcohol during use disorders 4.6 times greater than people with schizophrenia than the rest of the population. So people with schizophrenia tend to take different kinds of treatment. That's the hardest thing to deal with, is a lot of them struggle with medication compliance. This is a really good chart. I want to not going to get a lot into, but symptoms of severity and psychosis. You can see kind of from the DSM. The DSM-5 has some really good charts and information in there on psychosis information. So we're not going to get into that. It's in your DSM. Negative symptoms thought to be more debilitating. 90% of patients do not return to pre-illness level of vocation and functioning. So 90%, once they reach that level, they don't get better. It can be managed. You can manage your symptoms, but can they get back to doing what they did as a job? I don't know. 10% die by suicide. 1 out of 10 schizophrenic people die by suicide. A lot of suicidal thoughts and different things from schizophrenic people as well. Generally marked by chronic course exacerbation as well. Illnesses, so they do have more illnesses, more hospitalizations, and different things like that as well. So 20th century artist Louis Wayne, fascinated by cats, painted these pictures over a period of time which he developed schizophrenia. Pictures are marked progressive stages of the illness and exemplify what does victims perceive. So you can see the difference in the perception of cats from the same artist painting the same picture over the stages of schizophrenia. Yeah, a lot of good treatments. There's a lot of really good things people can take in those areas as well. Substance abuse disorder, we talked about this a little bit. A lot of medications out there now that can induce psychosis. Yeah.
Going back to schizophrenia, did they say in there what causes it, or did they just say like there's a possible genetic?
There is a strong genetic link, but they don't know what's actually causing it. They're still looking. Substance abuse, I don't want to get too much into that. We already talked a lot about this. Could be anything. Let's see here. Medical conditions, brain tumors, seizures, delirium, Huntington's disease, multiple sclerosis, Cushing's, vitamin deficiencies, electrolytes, thyroid disorders. You get the picture here? It could be anything. So you want to medically rule out anything you can rule out medically, because there's really good blood tests and other tests that can help deal with that. Don't assume that their physician knows they're psychotic. They may go to a urgent care, or their doctor may see them every once in a while and just like, I have a cold. Okay, here's antibiotic. You don't know. Delusional disorder, again, real life situation, people poisoning, love at a distance, deceived by a spouse, at least 1 month of a certain thought of that too. Prevalence is really low too. So anyways, a lot